Hello, everyone, and thank you for joining us for today's webinar, Behind the Scenes Insights from One Payer Striving to Optimize Alternative Payment Arrangements. Today's webinar is being presented by Edifecs. Before I introduce our speakers, I would like to cover a few housekeeping items. Today's webinar is being recorded. We'll be able to share a link with you after the event is complete. We'll welcome you to revisit the content and share it with colleagues. Everyone's microphones are muted. If you have a comment or question, we encourage you to use the Q&A chat box on your screen. If you think of a question for the speakers at any point, just type it in there and I will hold it for the discussion portion at the end of the event. Today's presenters are Dr. Summerpal Kahlon, Chief Medical Officer at Edifecs, and Dr. Kiran Rangarajan, Chief Government Programs Officer at Blue Cross Blue Shield of Rhode Island. Blue Cross Blue Shield of Rhode Island is a nonprofit, community-focused health plan established in 1939 to help Rhode Islanders finance their healthcare needs. Today, that purpose is still foundational to their work. They have a vision to improve health and well-being by leading access to high-quality, affordable, and equitable care. At this time, I'm going to hand it over to Dr. Kahlon to start the conversation.
All right, thank you, Ted, and thank you, Kiran, for joining me today as well. Welcome, everyone, and hopefully we'll have a lively discussion this afternoon. And if you have any questions, as Ted mentioned, feel free to put them in the chat box, and we'll try to address those at the end. So as we go through our conversation today, we're going to chat a little bit about Blue Cross Blue Shield Rhode Island for those who may not be familiar with the organization, and particularly the kind of innovation they've driven around alternative payment models. And then as we drive into the heart of the conversation, really want to talk about not only what are we doing, but how do we measure? So how do payers measure providers, and how can providers measure themselves to make sure that providers are not only being successful in terms of the APMs they participate in today, but also in the future, as we advance down the path of taking additional risk and moving into more innovative models. What are the things to look for that help set apart some providers from others and represent that ongoing journey towards value? So I'm joined today by Kiran, and as Ted mentioned, he's got a strong background at Blue Cross Blue Shield Rhode Island, and in particular, he's got a really good background in analytics and data-driven operations. So as we start off, Kiran, if you want to share a little bit more, Ted kind of gave the basics, but at Blue Cross Blue Shield Rhode Island, if you want to share a little bit about the organization and particularly, some of the value-based care innovation that you've driven up in the Northeast, which has really been, in many ways, the heart of the value-based care movement. So, Kiran, I'll turn it over to you if you want to share a little bit with the group about BCBS Rhode Island.
Great, thanks, Summer, and nice to be here and talk about some of the innovative approaches we have taken to VBC, right? So as everyone here probably knows, right, it's just VBC is nothing but advancing what we know as fee-for-service, but we understand that provider practices are different. They have different capabilities, different resources, different infrastructure. So it's really critical for us to look at providers and patients and look at other social elements that play along with that function to make it more valuable and effective VBC contracting approaches, right? So not everyone would fit in the VBC bucket. We understand the limitations. So we got to come up and be creative in the way we deliver some of these alternate payment methods, right? So we looked at shared savings, we look at provider caps, we look at global caps, to name some of the models that we have used here. One of the couple of most important things that we think is critical for VBC is understanding the attribution and how do we benchmark these across the network, because like I said, providers come with different flavors, infrastructure, clinical needs, their integrated networks, and the availability of providers within that space. So we had to think deep and look at all the various social factors that impact the model, and then come up with a more customized, tailored approaches for each ACOs or provider groups that we look at.
Thanks, Kiran. And you touched on attribution there. That's really sort of step one. Who are you taking care of? Who are you managing risk for as a provider? And I know for me, I've said before, for risk-bearing providers, you have to think like a payer, because in some ways that's what you are. You're managing financial risk based on various parameters in your contract. And it's important to really think like a payer and to be able to treat your patients, treat your members in an alternative payment model, thinking through that lens. So as you think about it as a payer, working with provider organizations in your region, how do you as a payer measure provider success?
Right. So essential for any payer is patient's health. Everything, the healthcare is centered around, it's patient-centric. It's around the members, accessibility to care, what kind of care management opportunities are there, care coordination. These are some of the very critical things when we look at from a VBC standpoint. So measurement of success, I think, is a very uh, collaborative approach we need to take. I think the providers need to understand the importance of what these metrics are, how we measure them. And I think there has to be more synchrony and symphony between the two groups to make this happen. So some of the measures we look at, like for example, if you take risk adjustment, right? How many annual wellness visits are you conducting? And why is annual wellness visit important parameter for us to measure? Because the more time we spend with the patients, the more clinical diagnosis we can identify and then build a care plan. So some of the metrics we look at is annual wellness visits. How many, what is the member seen rate? How many members are you looking at, or are you calling in and scheduling appointments for? Are you closing all the risk adjustment gaps and quality gaps that we need to look at? So we look at recapture rates of chronic conditions, and then we also measure how many new diagnoses have you guys identified on a day-to-day basis. We also look at cost. Cost is an important driver. As we all know, the claims expenses are shooting up through the roof. So we are looking at cost and looking at what kind of diagnoses are driving the cost up, what kind of procedures are driving the cost up. And so we pay particular attention to that. Needless to say, some of the measures we look at may not apply next year. So we got to retune, come back, and have the flexibility to work through that process as well. So while we don't keep some of our measurements relative, we try to keep it more absolute, but at the same time, we do have a flexibility to change up based on the changing needs within the spectrum and the region and what is coming in from a clinical standpoint. So, we look at cost, like I said, revenue standpoint, member rate, network availability, what is part of the clinical spectrum within that ACO, where are the gaps, how can we supplement that as a payer and help get some of those referrals going, and care coordination and care management. So we look at a broad spectrum, but at the center of all of this is patient care and patient need.
Thanks, Kiran. And you touched on something there I wanted to ask you to expand on a little bit. So in many cases, risk-bearing providers kind of sign up for an alternative payment model and then feel, okay, now it's on me to perform, right? Where am I going to find resources, data, reporting, that sort of thing?
Yep.
But as you reference, you have quite a bit of insight. You have different data sometimes than what the providers have, quite a bit of insight and knowledge and expertise as a payer. Any suggestions or advice you might have for risk-bearing providers on how to really collaborate and take advantage of the reporting and the resources that payers are able to provide to help provide mutual success here?
Yeah, and just to give a little bit of background, so I joined Blue Cross in 2021, and one of the first things when I looked at the program was lack of data sharing between providers and payers. And we started to have that discussion with the provider groups to say, like, what are we missing? How can we better the performance? Let's look at the VBC contracting. What is the key element that is missing? Was data sharing. So immediately we were tasked, or I took over the responsibility of building an analytics function within the organization. And the more we started looking at the data and looking at, we were able to unearth some of these gaps that were missing, or that the gaps that were evident, and the data sharing and data transparency that was missing. And when we reached out to the providers, the first thing they said is, we don't trust payer data. We don't trust anything that comes from you because we've often seen it's wrong. And the more we started dialoguing with the providers, we understood that many of our providers within our network heavily relied on EMR and just data within the EMR. And so there was some education from our standpoint to say, look, EMR is great, you're getting all the data, you're closing these gaps on a clinical front, but as a payer, we do a lot more function than just clinical data coming from an EMR. Yes, we have that information coming through claims, but we do retrospective medical record reviews. We get supplemental data from hospitals and other inpatient facilities. We also do suspecting using clinical data, pharmacy data, and other claims that are coming in. So there's a plethora of information that a payer has that we would love to surface and share with you, so you are able to, when you see a patient, provide a better care, build a better care transformation plan, and start trusting that data that we give you. So it was a constant dialogue for a good 6 months to a year, and we showed the value by getting the retrospective review data out to them, saying, okay, this data is coming from a specialist that is not within your EMR. You don't have that information. And we showed them the evidence. And the moment we started doing that, we started building trust with the provider groups. I think it is very, very critical for us to share information, but at the same time, ensure that the integrity of the data, the source of the data, is trusted and valued by the providers at the same time. So data sharing is critical for any APM strategy to be effective and worthwhile.
Yes, absolutely, Karen. I agree. And as you mentioned earlier, it's really all about the member, all about the patient, all about the member, and working together to make sure that we can collaboratively do the best we can on behalf of their health. And so as you look at the alternative payment model contracts that are out there, not only at your own organization, but as you look at some of the other models that are out there publicly, any advice to providers on how to make the most of their contracts? You touched on data sharing, closing gaps, but obviously that's just the beginning. Knowledge is the first step, knowing the opportunities. Any additional sort of advice you can give to suggest how providers can really be successful and make the most of their contracts?
Yes, I think a lot of it starts at the top with the leadership. And I think it's important for alignment with the leadership, the community, the provider leadership, and the payer leadership. I think we have to be on the same page, understand the responsibilities, and understand the limitations of what exists. So a lot of research also suggests that for a VBC to be extremely effective, there needs organizational alignment across the supply chain. The other important feature that a lot of organizations are now getting into is technology. I think it remains a very, very significant portion of value-based care. What we as payers sometimes forget is we think the only social factor that matters is patients. But when we take a step back, we also think providers are a social factor there. We have never considered anything about providers and their impact on the value-based care model. Post-COVID, if we have learned anything, it's providers are there's a huge attrition rate. Providers are burnt out. They are asked to do so many things by different payers, different processes, different platforms, different attestation forms. They only have 24 hours like everybody else, right? So there is a clear burnout that we need to consider when we look at VBC portions. So I think technology plays a critical role. And as we design systems, I think it's critical for us to not only consider patients, but also providers, and design a holistic system that takes away the administrative burden from the payers, from the providers, and let them focus on seeing patients. Let payers take care of the administrative functions behind the scenes. I think technology will play a critical role in the future. And I think it's important for us to recognize that, work with the provider groups, understand how can we drive value by looking at value-based functions, and not look at, hey, I need to do medical record review, give me all the documentation, and burden them on such requests when we can take over all of that function behind the scenes. So I think that is a critical part. I also believe retaining providers is critical for VBC success or APM success. So I think the more providers are in the market, they are integrated within the ACO and doing a better job. We need to ensure that they are in the network, they're aligned, they understand the value of these functions and deliver care appropriately. So I think it takes a whole village to be successful. And I think payers also play a very critical part along with the leadership in the provider space.
All right, thanks, Kiran. And you touched on alignment, and we've talked quite a bit of data. When you think about the continuum of value, so it's not something that just happens one time at one encounter at one patient visit. It's a continuous process, a longitudinal process to define and deliver value on behalf of individual members and larger populations. As you sort of think about, how actions today can drive into opportunities for success in the future, any thoughts there about how, provider organizations can build on their success with today's activities to drive success both today and tomorrow?
Yeah, it's a great question, and that is something that we are trying to drive our providers towards, is looking at data more prospectively than retrospectively. What can we do prospectively in terms of closing care gaps and risk gaps is important. I think we need to start paying attention to more prospective approaches now, and it's important to, like I said, absorb the data from the payer, get as much data as possible, and then curate that information and take care of the patients. The other critical aspect is investment into technology. I think there is no way there's nothing we can do to ignore technology. It has taken over. AI is coming on board, a lot of use cases around that. How can we start implementing the new age technology into our workflow has become imperative and ubiquitous. I think it'll be ubiquitous going forward. The other aspects that I think is really critical is bidirectional data flow in whatever shape, form that we are looking at least to begin with, right? If it's manual, that's okay. But over time, I think HL7 FHIR constructs will take over. A lot of payers are paying a lot of importance into that bidirectional flow, Blue Cross being one. We think clinical data from a suspecting proactive gap closure perspective is really, really important. So that is another measure that we need to start acting on today for us to be effective and fruitful in the future. And of course, like I mentioned, recruiting and retailing talent is an important function, be it data analytics, be it providers, clinical staff. I think it's important to retain talent and knowledge and experience. We have seen that patients, when we do our NPS surveys, when we look at patient and talk to them about their feedback and satisfaction, they rely on experienced doctors. They want doctors who have been in that region for many years, taking care of them, having best service. So I think it's clinicians play a critical role as well. As payers, we understand that. We want to supplement. We want to make sure we are giving the right incentives to the clinicians so they are able to sustain that level of effort and satisfaction with the patients. So I think it's a mix of both social factors, technology factors, and clinical factors that come into play. And I think if we start ignoring one or the other, we are going to fail in our approach to VBC.
Yeah, absolutely. And Kiran, you touched on the idea of closing gaps and doing so more prospectively or earlier in the year. So, for me, my own experience around risk adjustment in leading an ACO is the physicians in my own ACO would push back and say, well, this is just a financial activity. It's not my problem. It's not clinical. I don't need to do this. But, what I've tried to teach them and what I've learned myself over the years is effective risk adjustment is really effective documentation and best characterizing, in my opinion, how complex or how ill a member is, and knowing how much care they need and therefore how much value, so to speak, needs to be delivered to them to provide good care. As you look at the transition of organizations as they take on more risk, as they move from upside only to downside or even full risk, what are some things that you would provide as sort of nuggets or advice for those organizations that say, yeah, risk adjustment, we do that. We know how to do it, but knowing that it's important to do it kind of earlier in the cycle prospectively, but then also use that information, to drive other clinical activities to be successful, especially as organizations take on more risk with time. Any advice there based on what you've seen and what you've experienced?
Yeah, absolutely. So one, yes, as you mentioned, is the net present value of money. The faster we find, the faster we get the money, so we can start reinvesting that as a provider into other infrastructure needs or benefits. The other thing that you mentioned, and I think I want to stress upon a little bit more, is the faster we see the member or the earlier we see the member and we identify care needs. We all know getting into a specialist is difficult. Sometimes it takes months. And if a member has a very urgent and emerging need, doing it at the end of the year from a risk adjustment standpoint is not beneficial. So at least if we look at a member early on, we identify these conditions exist, we can get them into a specialist, get them treated, risk adjust. What some of the providers, like you mentioned, don't get it is the money upfront helps us pay for these benefits for the members too. So and it pays for the cost that they are taking to take care of the member. So the faster we get the money, we are able to supplement and pay the providers faster to take care of these members and balance the books. The other important aspect of looking at a member up front, like you mentioned, yes, it impacts risk, but it also brings in other care coordination teams into picture. Is there a need for them to, take care? Is there is an absolute opportunity to reduce cost? We are seeing some of the procedures are going high in the market. Is there an approach to proactively manage, for example, diabetes through education, through food, through other exercise means, right? We get the care team involved and we can address this situation before it balloons into a very, very expensive procedure down the road. So I think as provider groups, we have also seen, we know risk adjustment very well, but we have seen a lack of documentation within the system. So one example that a lot of our ACOs have come back and said, I don't want to put morbid obesity. My patients are worried, like morbid obesity, so we don't document them anymore. And we said, yeah, you don't want to put morbid obesity, but you can say class 3 obesity, and that risk adjusts, and that gives you additional dollars for you to take care of the members. So I think there's a path towards clinical documentation improvement as well that we can address, educate the providers on how to do that function, and capture better codes and faster and submit that to CMS for payment.
Yep, absolutely. And as you touched upon, it's important not only to understand the codes from that perspective, but also just knowing how complicated are they, how sick are they, so how much care do these folks need? And you touched on care management resources, the ability to kind of expedite getting into a specialist. Any sort of insight you can share with the group around, some of the things that can be done, again, in the spirit of doing things today that have an impact tomorrow? Anything you can share that can be done sort of earlier in the year, earlier in an APM performance cycle that can really help drive success, both within the current year and also, in the future, hopefully, as those, contracts continue and more risk is absorbed over time?
Yeah, I think it's understanding the patient population that is critical. What is the prevalence within the market today? What kind of special needs exist for which cohort of membership is critical to gather, and it's a continuous improvement opportunity. People change, unfortunately, people die, so new members age in. So it's really important for us to understand how to allocate resources. Where do we invest money in terms of needs coming into the payer market? What diseases are taking prevalence, and what is falling off the chart? So I think understanding the patient population, understanding the prevalence, I think is really, really critical, and data plays a critical part. So within our organization, we pride on analytics. We are working on a lot of prospective approaches to understand the patient population. We transfer that into other clinical teams within our organization to see what kind of programs can we come up with. And it's a very, very coordinated effort in our space. So we meet often. We bring our insights. We bring data. We discuss data. We discuss members who have acute conditions and what can we do as an organization to help them cross that burden. So I think, the importance is also providers. We need to share that insights with the providers. So we are doing that on a regular basis. We have seen huge improvements when the leaderships collaborate and we work as a team, the payer and the provider take care of the members. So I think that is very, very important to achieve success.
Yeah. Absolutely, I agree. So I'll ask you one last question, Kiran, before we open up to questions from the audience. Before I do, for the audience, you should be able to see in the chat box there the opportunity to chat in with questions. So please do go ahead and start asking your questions. We'll queue them up for the last few minutes of our conversation. And so before we get into audience questions, Kiran, one last sort of topic for you, and you touched on it a couple of times here: alignment between leadership in both organizations. So any sort of pearls of wisdom or any experience you can share where what alignment actually looks like. It's one thing to say, hey, we're both in a contract together, let's go be successful. But what does real collaboration, real partnership success really look like in your experience?
Yeah, I think the key is understanding the benchmarks. What are we looking at? What are we driving towards? What do we need to be successful? In order to be successful, what do we need to achieve? What we have seen is sometimes it's just misunderstanding between the groups. Somebody understands recapture rate as something else, for example, as a provider group. So I think it's getting down to the basics and saying, okay, these are the levers that we need to hit. This is how we measure. This is what we're going to look at. And what can we do to help you and support you through this journey? And we understand the providers, like I said, they come in different shapes, flavors, infrastructure needs, resources. So as a payer, being flexible, listening to the providers, understanding their problem and solving for that problem, and being, one size does not fit all. We understand that. And then so we try to be innovative in our infrastructure payments to the providers. We try to be innovative in terms of incentives we pay to the payers, so they are able to meet that benchmark to be successful. So I think alignment towards the objective, the goal, and understanding the gaps and understanding and working with the provider groups to bridge that gap, I think is critical to be successful.
Absolutely. I think, as you mentioned, it's extremely important to really understand the goals, be very clear between the organizations on the specific goals, and, plot that journey to value to achieve those goals. So absolutely makes sense. So, again, for anyone in the audience, we'll move into our Q&A section here. So feel free to text in any questions that you might have. Kiran, one question for you. You mentioned interoperability and data sharing a couple of times. Any guidance you can provide on perhaps technical, the best way to do that? There's lots of, health information exchanges out there, direct connections with FHIR and HL7. Any suggestions based on what you've seen that can be really effective?
I think, at least from our organization perspective, I think from a risk adjustment, I don't think risk adjustment just as a financial driver, right? I think it's a data acquisition exercise. We get a lot of information in the risk space that we then share amongst other groups, and the insights we find is really valuable. So I think doing some exhaustive retrospective review on medical records and the way to gather these information faster means and holistic means, I think, is important. I think the manual methods of targeting a particular population, just looking for that gap, doesn't work anymore. I think we have seen CMS mandates come out where we just, to avoid audit risk, we have to now look at every single medical record out there. And what we have seen is, by looking at that information at a broader scale, we have unearthed more gaps. We have seen more clinical documentation come in. And so I think from an interoperability standpoint, if we can develop a methodology where we are able to extract data from an EMR at an exhaustive scale, then the onesie, twosies, or manual approaches have, I think, really pays off. One, from a revenue standpoint, but two, also from an accurate and complete coding perspective and getting more clinical information through the doors.
Yeah, that makes a lot of sense. And so, Kiran, there's a question in from the chat. How can you establish stronger benchmarks to impact across organizations? So obviously there's basic goals that are outlined in any APM contract, but how do you go beyond that to really get more impactful benchmarks in that collaborative approach?
Again, I think it has to be a collaborative approach. We do understand a lot of payers, at least within our market, have just got into some of the global cap arrangements. I think it's important for us to give them time to scale up, to hit those benchmarks and build towards that organizational structure. Once they have it, we can always push them beyond limits to say, okay, we have achieved, let's say, 80% recapture. How can we shoot for 90% recapture? What do you need from us to achieve that? Is there more data sharing? Do you want more integrity in the data? What can we do to help support? I think it's a partnership again. And it's also important for payers not just to push strong benchmarks without understanding the limitations and the needs of the provider group. I think we need to work together, give them time to establish what they need to establish, and then push from there.
That makes sense. And it sounds like really what you're saying at the root is it's not a one-time conversation on January 1st. It's a continuous dialogue throughout the course of the year. Yes. And the performance period to be successful.
Exactly, so.
All right. Well, thanks, Karen. I know we're at 1 o'clock, so I want to respect everyone's time here and wrap up. But I want to thank you for attending, Karen, and sharing your insights. And I want to thank all the attendees for joining as well. So for anyone who has any questions or would like to reach out and learn a little bit more, please reach out to Abby, and she's our primary point of contact at Edifecs and can help navigate. But certainly we hope everybody found this valuable and picked up some good insights on how best to collaborate between risk-bearing providers and payers who are looking to advance down the path of value. So thank you, everyone. Hope you all have a nice afternoon, and please do reach out if you have any questions that come up after the session. And Karen, thanks again. Hope you have a great day.
Thanks, Summer. You as well. Thank you. Thanks, everyone. Bye.
Take care. Bye.
Okay, bye-bye.
Thank you.